Hello, my name is Eleni Rosalina Andrapoulou, and I'm from the Department of Biostatistics at Erasmus Medical Center. I would firstly like to thank the organizers for giving me this great opportunity to present here my work, and of course you for attending this session. The title of the presentation is Estimating Cystic Fibrosis Line Decline, an Empirical Study. The Cystic Fibrosis Foundation established a workgroup to examine the impact of differences in rate of decline estimation approaches. The workgroup committee consists of members from the Cystic Fibrosis Foundation, the Cincinnati Children's Hospital Medical Center, and the Erasmus Medical Center. There are no relationships to disclose related to this presentation. So first, I would like to start with the introduction and in particularly with the data that we used. We used the US Cystic Fibrosis Foundation patient registry data from 2003 until 2060. We included about 35,000 patients, and from those we excluded patients with missing pulmonary function, patients that were younger than 6 years old, and patients that received lung transplantation prior to 2003. The total number of patients was about 34,000, with more of 1 million observations. So the goal of the research is to investigate the variability in the analytic approaches to model FEV1 decline, and we will discuss the rationale for selected statistical approaches. We will investigate the differences between the models, the different assumptions and interpretation that we have, and then we will finish with the differences between data scenarios that we can assume. For example, what happens when we have a small sample size or a smaller follow-up period. So first, I would like to start with the challenge here that we face, and particularly in this figure, you can see the association between the statistical complexity and the clinical interpretation. And as you can see, those two are positively correlated. The more simple models you have, the more simple analysis and interpretation you get. So statisticians tend to model complex model that leads to a difficult clinical interpretation. And on the other hand, clinicians assume simple statistical models which lead to easy interpretation. But we are forgetting an important factor here, the factor data set. Here we can see the association between the statistical complexity and the data. And as you can see, we again have a positive correlation between them. So the more simple the data is, the more simple models we will need. If we look at the cystic fibrosis data set, we can see that they are complex. We have lots of patients information, lots of observation, lots of factors that influence the rate of decline of FEV1. And therefore, in order to observe valid results, we will have to assume a complex statistical model. We will continue with the methods. And the first step actually to decide which methods to assume is to check the special features that our outcome FEV1 has. And these are the multiple measurements within the same patients that are expected to be more correlated than measurements from different patients. We also have an unbalanced design, and that means that patients do not come at the same time point and don't have the same number of measurements. And FEV1 is measured with error, meaning that if we take two FEV1 measurements at the same, on the same day from the same patient, we don't expect to have the same value. And in order actually to tackle this, to take into account of these features, we can assume the following approaches. So we can use a mixed effects model, a generalized estimating equation, or a joint model of longitudinal and survival data. And these are actually the models that we will discuss in this presentation, and the models that have been previously used in the cystic fibrosis literature. So before we start, you need to keep in mind that each data set is unique, and there is no one model that fits all need solution, unfortunately. We will start with a mixed model, and we will assume that the yi represents the repeated measurement of our outcome for the ith patient. So these models consist of the fixed effects that represent the average evolution over time, and the random effects that represent the individual evolution over time. And some of the choices actually that we have to make here is the random effects structure. So if, for example, we use a random intercept structure, we will assume that the evolutions of each patient start at the same time point. Actually, the FEV1 starts at the same time point, but the evolutions are the same. So in this plot, we can see in dashed lines the evolution of FEV1 for each patient, and the solid line represents the average evolution. So as you can imagine, this might not be realistic in the cystic fibrosis dataset, since we expect that each patient would have his own evolution. And in order to do that, we can extend our mixed effects model and assume a random intercept and a random slope. Another thing that we need to take care is the linear evolution. So here we present the profiles of two patients. So we have one patient represented with a dashed purple line, which has more constant evolution over time, and we have the patient with a solid blue line. So this patient has a constant evolution over time. We see a steep decrease, and then again some stable measurements at the end. And therefore, a linear structure might not be appropriate for all the patients in the cystic fibrosis dataset. So in order to account for that, we can use polynomials, or even better, we can use spline. I will show you in a second what the differences between those two are. But in both cases, we have this disadvantage that we will have multiple not interpretable coefficients for the clinical audience. So now let's go into the difference between the polynomials and the spline, and let's assume that we have some BMI values over time and we want to fit a polynomial. So we assume a 4-degree polynomial. Now let's take this last purple point and change it into this blue point. So as you can see that even though the only change that we have done is here at the last point, the fitting part seems to change also in the beginning, so the two lines seem to be different. The advantage of splines is that they split the follow-up period in a number of intervals, and they assume polynomials in each of the intervals. And if we now go back to our example and we fit splines instead of polynomials, then we can see that the differences between the lines are very small. Basically, they are similar in the beginning, which makes more sense since we didn't change anything in the beginning. So another approach for longitudinal data is the generalized estimating equation. And these models are preferred when we have a small sample size because they require less assumption. And in that case, as you can see, we don't have random effects. We have only the fixed effects. And the correlation between the measurements that are taken from the same patient is taking into account in the variance-covariance matrix of the error terms. And actually, the advantage here is that we can have a very flexible covariance-variance matrix. So the disadvantage of the random effects is that it assumes that all observations are correlated equally regardless of separation in time. So basically, it doesn't matter if we have a gap of 2 months or 2 years, the correlation would be the same. But it would make more sense to assume that the further the 2 points are, the less correlation they have. And in order to do that, in the generalized estimating equation, we can assume an exponential covariance variance matrix for the error term. Of course, we can have mixed effects models that assume also a correlation structure. So for example, we can have our fixed effects, random intercept, and the variance covariance matrix as an exponential pattern in our error terms. You need to be careful here to not overdo it. So basically, you can't really assume a very complex random effects structure because this would lead in convergence problems in the model. And actually, this particular model has been previously proposed in the cystic fibrosis literature. So let's move now to the joint models. There could be different factors that could influence the FEV1 evolution. For example, some patients might die, might require transplantation, or can have exacerbation. Then it would make sense that since these factors could influence the evolution, to model them jointly. And in that case, we can use the framework of joint models for longitudinal and type 2 event data. The idea here is that we first fit a mixed model, and then we take the underlying value, which is the fixed effects and the random effects, and we plug it into a survival model. So alpha here will represent the association between the longitudinal and the survival outcome. And of course, we can correct for some baseline covariates. And the focus here could be either on the longitudinal or on the survival. So if the focus is on the longitudinal outcome, we actually want to investigate the evolution over time of our longitudinal outcome while accounting for possible dropout. And on the other hand, when the focus is on the survival outcome, we want to investigate the association between a time-dependent covariate measured with error, such as FEV1, with the survival outcome. And now we will describe the different data scenarios that we assume. So first of all, we used all the registry data. Then we investigate a different number of patients. So we assume a small sample size of 150, a medium 3,000, and a large of 30,000. We investigated the impact of follow-up on estimating FEV1 decline. So for example, what happens if we have a follow-up less than 2 years, a follow-up of 2 until 5 years, or a follow-up of more than 5 years. Then we investigated the FEV1 collection frequency, for example, when we have annual maximal, quarterly mean, quarterly maximum, and encounter level. And finally, we investigated the impact of exacerbation in estimating our decline by excluding or including the FEV1 measurements taken during exacerbation, or including or excluding exacerbation as a covariate in our model. The next question probably that you have is, how do we compare those models? So within each statistical approach, we can assume the following measures. In the mixed model, we can assume the Akaike information criteria, and the lower the value of this criteria is, the better the model is. In the joint model, we can assume the same Akaike information criteria, and for the generalized estimating equation, we need to assume the Cauchy information criteria. And now, what about the differences between the methods? In that case, we will have to compare the observed versus the predicted values, and we can do that with the following measures. So with the mean absolute deviation, the root mean squared error, or the correlation. Let's move on to the results now. In this plot, we can see the evolution over time, assuming all the data of FEV1, of course. And you can see that up to year 30, all models perform the same, and then we see some differences. For example, these first 3 lines represent the nonlinear models, nonlinear mixed models, and generalized estimating equations. These middle lines represent the linear models, and finally the blue with a steeper decline represent the joint model. So as you can see, the joint model actually predicts some negative FEV1 values. This can be explained by the fact that the joint models tries to predict what would have happened to the patients that died if they wouldn't have died. And of course, these patients had already small FEV1 values. So now, with regard to the linear versus nonlinear, our models indicated an approximately linear rate of decline until age 30, but the nonlinear model seems to fit better the data. In the case of the mixed model, we had to make some extra choices with regards to the structure of the random effects and the correlation structure. And in that case, we obtained that the model assuming a random intercept and a correlation structure provide us with the best fit. So if we now compare all the models, we can see that the model assuming, actually the mixed model assuming splines in both the fixed effects and the random effects seems to be better. However, we have to mention here that we didn't correct for over-optimism. So actually we use the same model to fit and to predict, which is not really correct. And we would have, in order to correct for that, we would have to use a bootstrapping approach or a cross-validation approach. If we now look at the different scenarios, we can see the results here. So here we focus on the linear model, since in that case we have one interpretable coefficient for the rate of decline, which makes it more easier to get an idea of what the result is. So what we see is a bigger variability in the mixed model. The joint model seems to provide us with a steeper decline. And if we see the different scenarios, we can see that if we have a small sample size, the confidence interval are wider. And for the scenario where we assume a follow-up between 2 and 5 years, the LME assumes a really a steeper decline compared to the other scenarios. So discussion, in this presentation, we gave an overview of the statistical models that have been used in the literature of cystic fibrosis, and we investigate also what happens when we assume different scenarios. some result highlights. So the nonlinear evolution seems to be the best for our data. However, up to year 30, we saw that the evolution is linear. And of course, the impact were similar across scenarios, except for the length of the follow-up and the sample size. I would like to thank you for your attention.
Hello all, thank you for your interest in watching our presentation today. I hope you are all doing well during these strange times. It is with great pleasure that I'm here today to share some preliminary results of our work to better understand the benefits of ivacaftor treatment on lung function in people with cystic fibrosis. This work comes from a working group established by the Cystic Fibrosis Foundation. The work group consists of members from the Cystic Fibrosis Foundation, the Cincinnati Children's Hospital Medical Center, and the Erasmus Medical Center. The slide is not big enough to acknowledge all members of the working group, but I'd like to point out that everyone's time and effort has been crucial to achieving the results that I will present here today. So I have no actual or potential conflict of interest in relation to this presentation. Respiratory failure is a primary cause of death for people with cystic fibrosis. Therefore, slowing the decline of pulmonary function is a key goal for cystic fibrosis therapies. There have been major improvements in cystic fibrosis outcomes over the past few decades, but as you may know, it's still very much a life-limiting condition. Some of these improvements are due to the development of new drugs, such as ivacaftor. This drug is used to treat people with specific mutations in the CFTR gene. In our study, we are interested in assessing the change in patients' lung function before and after the patient starts the ivacaftor therapy. In particular, we are looking to FEV1, which is a commonly measured marker of lung function that measures the forced expiratory volume of air from the lungs over 1 second. We use data from the US Cystic Fibrosis Foundation patient registry, which contains health-related information for around 31,000 patients. But since ivacaftor therapy is not well suited for all CFTR mutations that cystic fibrosis patients may have, it was necessary to select a sample from the registry population. First, we left censored all patients' follow-up at age 6, given that lung function cannot be reliably measured before this point. We also right-censored patients' follow-up at pregnancy or lung transplantation. We selected patients who have a G551D mutation. We then selected patients who received ivacaftor from January 2012. January 2012 because it's when ivacaftor was approved by the US Food and Drug Administration Agency, so the FDA. The patient's follow-up was then limited to a 6-year time window centered at baseline. At first, we defined baseline as the patient's first FEV1 measurement coded as beginning of ivacaftor treatment. This raised an important challenge that I will address and elaborate on a bit later. We then included subjects who had more than 2 FEV1 measures over 6 months from baseline while they were on ivacaftor therapy. In total, 810 patients met inclusion criteria, amounting to around 18,000 observations. The aim of this study was to create a model with FEV1 as the outcome and time since baseline is the only explanatory variable. So time is the only covariate present in our model. We assume the linear effect of time, and by incorporating a change point at baseline, we allowed an intercept and slope change after the treatment start. As you can see on this plot, highlighted in yellow and pink. In terms of the correlation structure, we assume the random intercept and the serial exponential correlation. On one end, the random intercept accounts for the variability between subjects, and on the other end, the serial correlation accounts for the correlation over time within subjects, meaning that measurements far apart in time are less correlated with each other, and vice versa. One important logical challenge is that registry data could have a slightly bias in the EVAC after initiation date. The true date of a patient's EVAC after initiation could be earlier or later than the first clinical visit in which treatment initiation was noted. This can be explained, for example, by a lag in insurance coverage beginning or an initial lack of EVAC after availability. Therefore, the discordance between the true treatment start date and recorded one in the registry could occur in either direction. This could be particularly problematic given our model formulation, in which we are imposing a change point at baseline. To assess the impact of this registry bias in our model estimates, we did some sensitivity analysis. Iteratively, we removed observations from our baseline in both directions and fit model again and check the model estimates. So that is, observations that fall within the pink region in the plot were removed, and then the model was fitted to the remaining data. Surprisingly, we noticed the following. At first, when the region has the duration of about 1 week, the deletion seems to have a bigger impact on left slope. But after that, when the region increases beyond that interval of 1 week, the results appear to remain more or less similar. On this plot, you can see how the width of the removal window affects some of the model parameters, in particular our fixed effects. On the x-axis, we have the window width, and on the y-axis, we have the parameter estimate. We can see that immediately after the observation flagged as treatment initiation is removed, the parameter estimates seem to plateau. This suggests that our registry bias skews in favor of a lag in the start date for therapy. In other words, at the visit that was coded at the beginning of treatment, the patient seemed to already being experiencing some of the benefits of the EVAC after treatment. These results led us to change our baseline, so from the FEV1 measurement at the visit coded at the beginning of the treatment to the observation immediately before. This change leads to a slightly smaller cohort, as some criteria in our inclusion-exclusion process depend on these baseline measurements. The new cohort has 722 participants, 88 less than previously. Here are the model estimates we obtain. The plot on the right gives us a better understanding of the meaning of the estimates of our model. So, but let's try to translate these numbers in words. So according to this model, patients with cystic fibrosis and a G551D mutation who receive EVAC after experience overall improvements in their lung function and a slower FEV1 rate of decline for up to 3 years. In particular, the model estimates that on average, these patients experience a 5.41 improvement in FEV1 % predicted and a decrease in the rate of decline of around 0.34 per year. So it means that after treatment start, we have a lower rate of decline, so a less steep progression. The natural history of cystic fibrosis is displayed in gray on the plot, which describes the progression of lung function over time in the absence of EVAC after treatment for these patients. I'd like to point out here that we are still exploring other model structures, and because of that, these estimates might not be the final ones. So in conclusion, these preliminary findings suggest that EVAC after is a disease-modifying therapy for the treatment of cystic fibrosis in patients with a G551D mutation. As for next steps, we are currently exploring other model structure. In particular, we are extending the analysis to check if FEV1 progression is better described to a nonlinear effect of time. And we are doing so by adding some splines in our model structure. Furthermore, we are also comparing the FEV1 rate of decline from this cohort of patients against a control group. So against other patient group who has a similar disease pathology, but who are not eligible to receive EVAC after. That concludes our presentation. Thank you very much for your attention. Your feedback and comments would be much appreciated and are very welcome. Before I conclude, I would like to address a special thanks to the people with cystic fibrosis and their families who agreed to make their data available in the registry for research purposes. Without their consent, work like this would not be possible. Thank you very much.
Hi, my name is Rebecca Cosgriff. I'm the Director of Data and Quality Improvement at the Cystic Fibrosis Trust in the UK, and I'm going to talk about a paper that I published with collaborators from the Global Registry Harmonisation Group on characterising COVID-19 in people with cystic fibrosis. I don't have any relationships to disclose. So we published 40 cases from 8 countries around the world in a short communication in the Journal of Cystic Fibrosis back in April 2020, earlier this year. And I'm going to talk you through the background, methods and results of that paper. So by way of background, as I'm sure you're all aware, by around March 2020, many countries around the world had identified people with cystic fibrosis as being clinically vulnerable to COVID-19. Around that time, the UK Cystic Fibrosis Registry had set up real-time monitoring of COVID-19 amongst people with cystic fibrosis, recognising the need for our clinical and patient community to have as much information as quickly as possible about an infection that was poorly understood in the general population, but particularly amongst people with CF. The way we set that monitoring up was that the registry team actually set up a helpline that clinical teams could get in touch with, simply referring their own name and contact details for the registry team to give them a call back. This was useful for a number of reasons. It was low burden on very, very busy clinical teams who were supporting the effort to combat COVID-19 in the general population, as well as trying to protect their CF patients. What it meant was that the Cystic Fibrosis Registry team simply called back the clinicians in a way that took very little of their time. It didn't involve them having to log into the registry or spend time doing that, and used a script to extract the information that we felt at that time was the most important when monitoring COVID-19. Because we didn't really know at that early stage what necessarily all of the important factors would be, it was much easier for the registry team to coordinate using a script to extract that information from clinical teams that could be adapted at short notice, only having to retrain 1 or 2 people from the registry team, rather than having a national data collection process put in place that would mean continuously retraining the entire clinical community whenever we decided to add or adapt one of the measures that we were collecting. It also meant that we were able to collect data in real time, whereas in the UK, the registry is still a retrospective system. So data tends to have at least a 2-week lag before it gets onto our system. And doing it this way meant that we heard about cases as they happened. So using this type of data collection model, the Global Registry Harmonisation Group set up extraordinary meetings, meeting on a twice-monthly basis, and each individual country set up its own data collection method. And really, as a group, we very quickly identified that there was an urgent need for as much information to be put in the public domain as quickly as possible. So we pursued a really rapid publication of as many cases as we could get within a short time frame to have some information on COVID-19 in people with cystic fibrosis available rather than none. So the methods that we use were all with the aim of describing the clinical course of COVID-19 in people with cystic fibrosis who acquired the infection and had that diagnosis in a hospital environment. The way we did that was by using a minimum data set that was within a data collection template that was agreed by the whole group. All countries were included if they could meet the very strict and quite harsh 13th of April 2020 deadline. So we knew that the data had to get into the public domain as quickly as possible. Unfortunately, at that early stage, it did mean we couldn't include every single country. Cystic fibrosis registries in each country contacted their care centres to request the data. Some of them used a method like that which I described in the UK, where we had this sort of outside of the registry method of collecting data that was then added to the registry system by the core registry team. Others had data collection within their own registries according to their sort of normal infrastructure quite quickly. Completely anonymised data were then extracted from those data collection systems at a national level and submitted centrally for aggregation, data cleaning and analysis, basically. Neither the submitting CF centre or the person with cystic fibrosis were identified in those data collection templates, I should say. And because of the way that we collected data, it's really important to understand that we aimed to describe the clinical course of COVID-19 amongst people with cystic fibrosis. It wasn't our objective to describe the incidence of COVID-19 in the whole cystic fibrosis population. And the reason we couldn't do that is because of our eligibility criteria. So we only included cases diagnosed by a clinical team in a hospital setting through PCR testing. We excluded CT-only diagnoses, clinical team opinion-only diagnoses, and we couldn't include any self-reported instances of COVID-19. So where someone with cystic fibrosis has had a test done at home, tested positive, but not actually encountered their clinical team, we couldn't include those cases. So it's clear now that we couldn't try and estimate the overall incidence of COVID-19 when some people would have been completely asymptomatic and not had a test, but also some of those people, even with positive tests, wouldn't have met our inclusion criteria, which we instated to try and make sure that the cases we were included were as standardised as possible. And we made sure that every country had a shared understanding of those cases that were included. We did include unresolved cases, so they were published as part of the analysis. And where we had a query on a particular data item, they were funneled through the country coordinator that was associated with each national registry. When it came to presenting the results, which I'm going to show you in a second, we stratified those by underlying CF severity, which we estimated by annual best lung function. So this is the best FEV % predicted measure that was taken in the year prior to their COVID-19 infection. So before I move on to the results, I think it's important to explain why we decided to use registries and the Global Registry Harmonisation Group as a centralisation point for COVID-19 in cystic fibrosis. And there are a number of reasons why we did this. There was an existing global collaboration within this harmonisation group with named coordinators, which meant that it was very quick and easy to get something set up and going that was as inclusive as possible. Those coordinators had links with CF centres across the whole of each country for maximum coverage. Excuse me. And we had access to historic data because those data were connected to the information stored within each CF registry. As well as historic data, storing information connected to CF registries means that over time we'll have automatic long-term follow-up of cases that are diagnosed with COVID-19. In terms of information governance, using registries was really important because they have existing consent models amongst people with cystic fibrosis and families. They have information governance approvals and all of the information technology security that is needed to store sensitive information. Most CF registries are associated with patient organisations, along with the direct buy-in from individuals with cystic fibrosis, meaning that this was as patient-centric a project as it possibly could be from the outset. So in terms of results, as I've already mentioned, we had 8 countries who were able to gain all of the approvals that they needed and collect and submit data by the deadline of the 13th of April 2020. And those countries are displayed on the map, but for those of you that don't have the kind of intense sight that you'd need to be able to see all of those countries on such a small graph, those countries were Australia, Canada, France, Ireland, the Netherlands, New Zealand, which actually reported 0 cases, the UK and the USA. And the characteristics of those 40 cases were that the median age was 33 years old, and we had only 1 patient who was less than 16 years old. 1 patient in the cohort was pregnant when they were diagnosed with COVID-19 and went on to deliver a healthy baby. And 11 of those patients were post-lung transplant. 38% were recorded as having cystic fibrosis-related diabetes, or CFRD. And 70% of patients had a chronic bacterial pulmonary infection, of which 71% were Pseudomonas aeruginosa. For the patients who were post-transplant, the average amount of time that had elapsed since their transplant was 6 years, but the range was between 1 and 15 years post-transplant for those people who had had a lung transplant who then acquired COVID-19. The presentation of COVID-19 was that 78% of the group overall were symptomatic at presentation. And 24 of those 31 had a fever, and that's 60% of those that were symptomatic. What you can see is that in the post-transplant group, a far higher number, 91%, were symptomatic at presentation than the group overall, and that might be associated with closer monitoring for symptoms of people with CF who were post-transplant. In terms of management, 63% of our cohort of 40 started on new antibiotics after being diagnosed with COVID-19, and actually very small numbers at that point were requiring intensive intervention. So some of the proportions are reasonably high in the post-transplant group, so 55% requiring new supplementary oxygen, but that's only 6 individuals overall. And in terms of invasive ventilation, we only had 1 person in the entire cohort who required that intervention. In terms of outcomes of COVID-19, as far as we're able to monitor them at this stage, we didn't have any deaths reported in that cohort of 40 at the time of reporting, and actually the majority had recovered from their infection by the time we were reporting on their cases. So you can see that in the overall group, we had 70% of people who clinically resolved at time of reporting, and 12 individuals who had not yet resolved of their COVID infection at the time of reporting. But it's worth remembering that the data deadline was the 13th of April, but some of those cases had their initial COVID-19 diagnosis quite close to that deadline. So it's more that they hadn't yet had the opportunity to resolve their infection than necessarily it being a more severe manifestation of COVID-19. And as I say, we haven't had any deaths in that cohort. So in conclusion, at the point that we reported this in April 2020, this gave some early reassurance that COVID-19 and cystic fibrosis may not be severe in all cases. Low incidence of infection requiring contact with the clinical team could have been associated with effective shielding by people with cystic fibrosis, or perhaps a protective effect of the relatively young age of our population. But as I've said, we couldn't estimate incidence in the overall population, only incidence of those severe cases that necessarily required intervention by the clinical team. Going forward, more cases and longer term outcomes were needed to really understand the risk of COVID-19 amongst this cohort. And I feel that we'd also established as part of this project that the Global Harmonisation Group of Registries was an effective means of monitoring COVID-19 in real time amongst people with cystic fibrosis. And we were very much collaborating and in touch with the European Cystic Fibrosis Society's patient registry, which set up its own monitoring process, which is available online on its website. So the next steps for the group at that point were to refine the data collection template in terms of incorporating lessons learned from our first round of data collection, and focus on involving more countries so that the results that we were presenting in future were truly a representation of the global picture of what was going on with COVID-19 and cystic fibrosis. And for an early report on 181 cases that we were able to glean from 19 countries that were involved in that second stage, please take a look at Symposium 1 and the presentation titled International Perspective on COVID-19, which I presented on behalf of that Global Registry Harmonisation Group. It's also really important as a next step to develop our understanding of the ripple effect of the COVID-19 pandemic on people with cystic fibrosis. So that's the impact on the health and well-being of people with CF who aren't necessarily acquiring COVID-19, but are impacted by the fact that there is a global pandemic. And there's a poster, number 16H, which talks about the displacement of cystic fibrosis services in England during the peak of the pandemic here. So it just falls to me to say that it's been an absolute joy to work with my collaborators, who you can see on the screen here. I took a sneaky pic of them during one of our teleconferences, who helped put together that first publication of 40 cases, and all of whom were also involved in our follow-up of 181 cases. It's a real pleasure to be able to present on behalf of such an amazing, hard-working group of dedicated people. I also want to say thank you to people with cystic fibrosis whose consent to and participation with cystic fibrosis registries meant that we were able to turn around the monitoring and reporting of cases so quickly, and also to the CF teams around the world who were taking care of people with cystic fibrosis during this time and spent a lot of time and energy making sure that that data came to us so quickly. Thank you to the Journal of Cystic Fibrosis, who turned around our paper with incredible speed, whiplash speed, again recognising the importance of getting that information in the public domain so quickly. I've already said thank you to our authors, but I'm happy to say it again. Their names are displayed on the screen there. And I also want to thank our collaborators who were involved in that first 40 cases of data collection. They're on the screen there. We couldn't have done it without them, of course, and I'm really grateful for their input and collaboration. And grateful to you for listening to this presentation. Thank you for your attention.